Mandy, I am very appreciative of the invitation. I was hoping to join in person. I'm sorry I can't. And I'm not off to a good start by hoping to get an invite to next year's conference by being a little bit late. So I hope it worked out okay. I think most of my talk is done. It was covered by my introduction. My hope is to talk about the other Niemann Pick disease, which is, as you very well stated, acid sphingomyelinase deficiency. Everyone else calls it ASMD because no one else can say acid sphingomyelinase deficiency. I've been practicing for years.
Rubbing it in.
And
Rubbing it in.
a little bit about who I am. I volunteer for the National Niemann Pick Disease Foundation and the International Niemann Pick Disease Alliance, INPDA, as well as the registry. I've sat on some advisory boards for Zevra, Azafaros, Sanofi, and Mallinckrodt. Mostly I'm a Niemann Pick parent and an advocate. I happen to be one of those GPs that before all of this happened did not know much about Niemann Pick disease and would very much appreciate the information that we were talking about sharing earlier. I'm going to talk a little bit about how we got the name Niemann Pick disease for both the disease that you all are probably more familiar with and the one that I'm a little bit more familiar with. I'm going to talk about the disease in terms of its onset of symptoms and its severity, just so you can understand it a little bit better. I'd like to talk about research, treatment, unmet need, and also talk about the common goals that I think the two communities share. How we got to be one community, at least in the US, and I think probably more likely globally, and some of the people that have played a part in that. So a little bit of a history lesson too. The history lesson starts with these two. I stole this offline. This is Dr. Albert Niemann and Dr. Ledwood Pick. They are the physicians and pathologists that first described this disease almost 100 years ago now. First identifying a patient, and then Dr. Pick looking at the pathology slides and noting something that looked like foamy cells, which was lipid stored in macrophages. And it was several decades later when two clinicians, Crocker and Farber, published the review of 18 Niemann Pick patients, probably both A, B, and C involved in all of this. And they talked about a wide variability in onset and clinical expression. So my guess is that they stewed on that paper for 4 years, and then they came out with what they termed Niemann Pick type A, B, C, and D together. And Niemann Pick A was characterized by a very severe disease. They had a lot of visceral involvement as far as the cholesterol being stored in all of the organs, but primarily the liver and the spleen is my guess, but also a lot involved in the brain with a lot of neurologic damage. Niemann Pick type B was thought to be a more chronic form of the disease, but sparing the nervous system at that time. And then Niemann Pick type C was characterized by a lot of neurologic or neurovisceral damage, both. And there was a wide clinical variability, which fits the type C that we all know with the types that have been well described by a lot of more recent studies. There was also a type D that was thought maybe to be a different disease, but it was a group of patients who all had the same type of mutation that all lived in the same location in Nova Scotia. So actually, they probably had type C as well. And so in thinking about the diseases as they were named back then, they were 4 different names, but really it was 2 different diseases with a spectrum disease of type A and B, and then Niemann Pick type C and D actually being the same disease. We've identified the genes that cause the problems with cholesterol accumulation. It's a little bit different for the 2 diseases, but not so dissimilar that we don't have similar symptoms that result in probably common pathways to try and treat that. ASMD, which is what I'll call it for the rest of the talk, has been called Niemann Pick type A and B, and the abnormalities in the SMPD1 gene, and I'll talk about that in a little bit more. And you all know about NPC, and you have experts there that should speak to that probably a lot more in this conference. I will draw your attention to the circles down below. We really didn't we had 2 separate sort of diseases described almost 100 years ago, and it really remained that way until probably 15 or 20 years ago, when there was a variant that was identified that wasn't quite A and wasn't quite B, and we'll talk about that in a little bit too. So this is a cartoon that talks a little bit about on a molecular level what this disease is. Again, it's a autosomal recessive disorder similar to Niemann Pick type C. So you need abnormal genes from both of the parents in order to have the disease. Niemann Pick type A probably you need almost no enzyme activity to have Niemann Pick type A. We believe that a lower enzyme activity puts you at higher risk for not making enough enzyme for the brain. And the brain is one of those organs that can get by with just a little bit of enzyme. And so for people with Niemann Pick type B, they often have relatively normal neurologic disease or very little manifestations. But you do see a lot of the other cells and other organs within the body that are affected. And I took stole this slide off the internet as well, but those foam cells or lipid-laden macrophages are pictured down below on one of the stains that might have come from the liver, where you're seeing sphingomyelin accumulate. And sphingomyelin is one of the lipids that's very common to make cell membranes. So it's found in a lot of different places. And the sphingomyelin should be able to be broken down, and when it can't be broken down, it builds up in the tissues. And the cartoon here showing pictures of the brain, the spleen, the liver, and the lungs, which we'll go over here in a little while. But we see again, the lysosome is the primary area where that starts to store up, but really the whole cell can be involved. And so when you think about clinical manifestations for ASMD, really the whole body can be involved. The most common sign of the disease that can be obviously seen in talking with someone or examining someone with this disease is the massively enlarged liver and spleen. The spleen can be 20 to 30 times the upper limit of normal, and the liver gets quite enlarged to the point where they can be so swollen that they go down into the pelvis. And the reason that they're swollen is that they're accumulating all that extra lipid within them. The other location that we see the lipid causing problems in all patients is within the lungs. And as the lipid accumulates in the lungs, their ability to exchange oxygen and carbon dioxide is worse. And so while not everyone requires oxygen, people describe a lot of fatigue associated with this disease and exercise intolerance. And it's thought to probably be at least partially related to the lung disease that is seen. A lot of bone abnormalities, fractures, and pain are also present in a majority of the patients. Nausea, vomiting, and other GI symptoms are also common. And most of the patients have abnormal blood cell counts, particularly low platelets, and bleeding is often a problem for these patients where they may have spontaneous nosebleeds or bleeds in other locations. So how did we get to ASMD from Niemann Pick type A and B? Well, one of the reasons is that we have an intermediate phenotype that developed here, this type AB, and the patients would have onset of symptoms in infancy to childhood, and they would have neurologic symptoms, but they were variable. They weren't as severe as the type A, but were obviously different than the type B. And their life expectancy was probably about 10 years to be understood when it was named. The type A have a very severe disease. It's rapidly progressive. The onset often isn't until 5 or 6 months, where the babies are usually growing and reaching milestones. But then when they start to develop symptoms, there's a fairly rapid stop of progress and then a recession in the markers that we look at for development. And many of those patients, some sit up, but most never walk, most never speak. And sadly, most don't make it to the age of 3. The neurodegeneration probably has a big impact on the swallowing, but also the visceral disease is usually pretty marked, and often the liver problems and GI problems and lung problems all compound each other. On the other end of the spectrum, the type B, which is on the far right, can present in early infancy, and there are patients who present within the first couple of years of life with symptoms maybe of an enlarged spleen or liver, potentially low blood counts, but they tend to progress more slowly and over time. Sometimes a diagnosis is made, but sometimes it's not made until adulthood when things are looked at again. It's thought that there's little to no neurologic involvement in these patients, although more recent studies suggest that if you look at the cranial nerves, especially the optic nerve, you can often see involvement at least there. So they probably do have some element of mild disease, but it's not nearly as impactful as those that have the type AB or the type A disease. The life expectancy is still limited in those patients without treatment. The estimated life expectancy is around 30 years, although the studies in that vary pretty widely as far as the estimated life expectancy. I put some different revised nomenclature. This is actually a slide I used to prevent at CMS about 5 years ago when we proposed to change the coding in the United States to move away from this type A, type AB, and type B to ASMD, to infantile neurovisceral instead of type A, to chronic neurovisceral in the place of AB, and to chronic visceral instead of type B. So we have all these longer words. I'm actually one of your people to blame for all of this and having to learn how to pronounce sphingomyelin. So why would we do that? What I told CMS at the time was that A, B, and B are hard for clinicians and sometimes for patients to avoid stereotyping or categorizing into one specific disease bucket. So in other words, it's a spectrum disorder, and there are often patients that aren't absolutely A, B, or B, and we wanted to have a better understanding that it was all one disorder and not two or three different disorders. So hopefully this aligned with the researchers, the clinicians, and the organizations. And the more descriptive terms of infantile neurovisceral, chronic neurovisceral, and chronic visceral hopefully better explain the disease than using letters A, B, and B. A lot of the other lysosomal storage diseases also use similar names, and so we're hoping that it would help with that as well to be more consistent with the other LSD community and establish accurate prognoses for patients, for clinicians that didn't see this a lot. So CMS took us up on this. They changed the nomenclature, and it's more widely known in the community now, I think, by ASMD. It helps that we have an approved therapy that I'll talk about later. But it was interesting after we did this. There were many patients that were very attached to being Niemann Pick and to be a type B or something like that. So there was a lot of discussion as to what was driving this and if it was the right thing for the community. But overall, I think we've made the shift, and I think it makes sense because it is all one disease, not separate diseases. And now that we have an approved therapy, our goal is to really allow all patients to have access or the ability to think about having this and having the disease as one name rather than two or three different names hopefully helps with approvals and access to this therapy. I talked a little bit about the intermediate phenotype and the really large spleen and liver, and so sometimes I think a picture's worth 1,000 words. I think the most classic patient we have in the community as the intermediate phenotype is actually my son. And the images of his enlarged spleen and liver in this image, and just how small he was when he was, I think, 4 years old when this picture was taken, are demonstrated here. And I'm going to try and move things around so I can play a video. The things I draw your attention to, again, his big belly is just because he has gigantic organs. He was actually pretty underweight for his age, and you can see how skinny his arms are and his legs are, and you'll be able to see his ribs quite a bit in this picture. And moving around, he has a little bit of ataxia here. It's actually gotten worse over time now that I look back on it. He's several years older now, but I'll just let the video play here.
What are you doing?
There's a lot of sports being played at our house by all the kids, including him. So, so in thinking about the treatment that was developed for this, and you may all know in the room that there is an approved therapy, an enzyme replacement therapy. It's a bit of an interesting story. It started quite a long time ago, and this paper was actually published 24 years ago, I think, where Ed Schuckman and his team at Mount Sinai took this enzyme, and they'd isolated the enzyme that's missing that breaks down the sphingomyelin. and attached it to a marker so it would be taken up into cells, and they infused it into mice that had Niemann Pick disease. And Ed did this study, and he also happened to create the mouse model for this disease. And they found that over a period of treatment that mice tolerated this therapy pretty well, and it helped with the liver and the spleen size. It's interesting in that the mice, the first time around when they injected this enzyme, didn't do so hot. In fact, they developed fevers and renal failure, and some of them passed away. And so that was a little bit of a shock. But what they learned is if you break down sphingomyelin rapidly and there's too much of the byproduct ceramide, which is the next lipid made that's released into the system, that the body doesn't do well with high levels of that. And so Ed very thoughtfully figured out that if he starts at a lower dose and worked his way up, he could break down the amount of lipid in the body slowly over a few months. And you can see he started at lower doses already in the animal model here and was starting to work his way up, and suggested that there's a dose escalation with this drug. And it's unique. Not all, or I should say most enzymes don't have to be administered through this route of dose escalation, but this is one that Ed suggested that we do. And the dosing of 0.3 and 1 and 3 are the same doses that we used in humans. And I'm not quite sure. We need to ask Ed how he came up with those doses, but they seem to work pretty well in people. And over the period of over 20 years, a drug company named Genzyme and then Sanofi studied this in patients. And in the clinical trials, they identified that, yes, it does shrink the liver and shrink the spleen, but the FDA in particular was very keen on what's the patient-reported outcome related to this. What does it actually do for patients? Does shrinking the spleen and the liver or removing the lipid from the lung really matter? And the patient-reported outcome in the pediatric trial wasn't ever published. And in the adult trial, the patient-reported outcome they tried to use actually didn't meet significance, which means the adults receiving placebo and the adults receiving the enzyme replacement therapy both reported the same amount of improvement. So the community came together, and we really leveraged the registry in this, and did our own retrospective analysis of what the patient experience was like for those who had a long experience on this study drug. And we were able to do it in as scientific way as possible. We had a third party involved. We did a couple different interviews, and we published our data, and we actually gave it to the FDA, and the FDA seemed quite interested in it. And so in thinking about what a community can do and how valuable the patient voice is, I think that this experience really mattered for us, especially in the US, but I think globally, we've tried to use this to help define the patient experience and help understand what living with the disease is like, but also how meaningful this enzyme replacement therapy is that was named olipidase alpha. And this drug was approved. It was approved in, I think Japan was the first country, and then the EMA approved it in 2022, and then I think about 5 or 6 months later, the FDA approved it. They have slightly different labels. The label in the European Union says, and they use the nomenclature A, B, and B, and they said it's approved for certain types of the disorder. The FDA said it's approved for ASMD, and it's approved for all patients to treat the visceral symptoms. The reason it's not approved for type A, and the reason it's only approved for visceral symptoms is this, like many enzyme replacement therapies, does not cross the blood-brain barrier. So patients with significant neurologic disease were excluded from these trials, and there were really no parts of the study that evaluated neurologic function, because it's not thought that this would impact neurologic function in any way, shape, or form. I bring up the FDA. I've been to this building a couple of times as an advocate, mostly on the NPC side, actually, but also nice to highlight where we are today and how living in a different country can be so different in terms of drug access. In the US, the FDA approval was followed by relatively rapid access to this therapy for patients who live in the United States. Payers, despite a very, very significant cost, were willing to pay based on the information available, potentially even from that article that the INPD helped put together. And so there really aren't any patients in the US who want access to olipudase alpha who have this disease who aren't able to get it. Tony Matheson has been amazing in the UK in leading the goal to have NICE provide access for patients in the UK. And there's over 30 patients who are trying to get access right now. And despite having an approval in 2022, NICE declined this therapy for a few different reasons. And that's a whole nother talk. She's appealing and done more appeals. And she's got a lot of help from the global community to try and fight this. But as of right now, those patients don't have access to this therapy despite it being approved. And it's obviously, from my standpoint, horrific that this one approved therapy that is, again, life-changing and life-giving it is not available in one of the more developed countries in the world. But it's been a good example for me of the importance of the patient voice and what advocacy is going to be needed, because these drugs, they're expensive to produce and they're expensive to pay for. And I understand that there are budgets and things like that for some of these health companies, but it's probably more to come as we think about what it takes to approve a drug and how much these therapies are going to cost. So a problem we're working on. I'm very glad we have an international group that can work on this from an advocacy standpoint, because I do think it's helping. I just wanted to show a picture of some of the Niemann Pick patients in the community. These are the faces that are out there, and a couple of our strong advocates, including the president of the INPDA, Sandy Cowie, who's been living with this disease for a few decades without any therapy. And 3 of these 4 people participated in the clinical trials that went over 10 years. And so appreciate all their efforts in advocating and being part of these treatment programs. These are other faces of patients with Niemann Pick disease. These are faces of patients with Niemann Pick type A. This was at the Wilder Nation Gala approximately 3 years ago. That's not a great clarity as far as the photo of the Laffoon family on the far left. Shannon Laffoon is seen in the middle holding her first son, Wilder, who passed away with Niemann Pick disease type A. And both Shannon and Stephen made a promise at Wilder's passing, which was around the age of 2.5, that they would dedicate their lives to trying to identify cures and support patients with Niemann Pick type A. And they have done an amazing job over the last many years of supporting research globally in the community. And really all work that has been done has been because of Stephen and Shannon's hard work and their organization's hard work. And they deserve a particular shout out for the research that has been done and what they've done as a family. And they work closely with this guy who is Ed Schuckman. Ed is really has done it all in the ASMD space. He isolated the gene. He created the first newborn screening in ASMD, created the mouse model. He's the one that created the enzyme that I showed you his paper from the year 2000. And anyone who's working in this space, they go to Ed first to try and figure out if their idea is going to hit or if they need to go back to the drawing board. And he gives of his time very freely. He still is very busy practicing and traveling around. We really owe it to Ed to have an approved therapy in this space. And Ed is actually the one that suggested that the NPC family community, which was starting at the NIH many decades ago, consider partnering with the ASMD community, at then the Niemann Pick type AB community, to have a shared advocacy organization rather than either one trying to start one alone. And so when they came together, it was the NPC folks led by the Greens in the UK that invited the Niemann Pick type A and B families in, and they ended up sharing a national patient and then international patient organizations. So good call by Ed, and one of the reasons that we share conferences and I think have a shared mission. I told you I'd talk about therapeutic targets, and we're looking at a few things. The endocannabinoid receptor blocker was something identified by the Wilder Nation Foundation's research. as a potential target. And there are endocannabinoid receptor blockers that are being studied for diseases like chronic pain, neuropathy, attention deficit hyperactivity disorder, ADHD, and potentially PTSD. And these drugs bind at the endocannabinoid receptor in the central nervous system. And when you use these drugs on Niemann Pick cells, there seems to be a hit there. And there were actually really good results in the mouse model. A mouse is not a human. But there are patients in the United States who through compassionate use or a managed access program, we're able to get access to these medications, not through a clinical trial, but to take them as a compassionate use that had Niemann Pick type A. They appear to be safe. It's really hard to demonstrate efficacy in an N of 1 trial, but it's something that is being looked at. And we hope that maybe at some point, if the data looks good from animal models and or these patients who are doing N of 1 trials, that there may be a clinical program that has to do with this. There's a company called B-Bio that presented a poster at the World a meeting this last year that talked about using B cells to produce the enzyme. So rather than getting enzyme infused all the time, you can have your B cells modified and they can produce the enzyme. The other idea that's been thrown around for quite some time, and Ed did this study decades ago, was to inject enzyme directly into the central nervous system. And that has been looked at. There are some problems with getting such large molecule in the central nervous system to do what you want it to do. So it's not something that's being looked at clinically at this point in time. And then gene therapy, which I left off and should have included here, is another target that's been looked at for both the peripheral disease that potentially could be used as an IV infusion, but also injected into the central nervous system as well. In the last few minutes, I'd like to talk a little bit about the shared priorities and missions between the two diseases and the two communities. We're all looking to get to crack that CNS barrier. And as we think about this, I think there's actually therapies that are being looked at in NPC that are likely to probably be effective in ASMD, and we're maybe thought about having clinical trials in those. So it's likely that we could have shared therapies, and we all need to try and figure out how we get treatments for the CNS. The last slide about improved clinical trials, we also have to figure out how we design a clinical trial so we can show stabilization of the central nervous system. As we all know, if we could just stabilize the neurologic formation of these diseases, it'd be a win. But that's really hard to show in very small clinical trials with the disease being so heterogeneous. And that's the same with the neurologic disease that's associated with ASMD. And so we're working primarily in the NPC space here in the US with CPATH to try and figure out if there are biomarkers or digital health technology things that we can implement into or put into clinical trials that can make them effective, so we can show regulators that the therapies that are being evaluated, if there is a meaningful benefit to us, and not have to have really long clinical trials. We're all going to need to work together to ensure there's access to these approved therapies. And I think, olipidase alpha, or Xenpozyme as it's called, is a nice trial run. We're hoping to get a lot more approved therapies, and we're going to need to figure out how we make sure these are all accessible to all patients. I think the registry is our most valuable tool. I think Solomon is speaking after me. I don't want to steal any of his thunder. But I'm a very strong advocate for it. I think it's our greatest tool in trying to help bring researchers into the space and to trying to help with the monitoring of the drug and to support growth and interest in the space from the scientific community. One of my passions is newborn screening. I heard it referenced a little bit earlier in the talk. I want to say cahoots somewhere in the talk, so I didn't sound old either. I haven't found a good place to do it, so I'll say it now. But we talked about newborn screening. I'm working on both NPC and ASMD. And I think working together in partnership has been helpful, and we're working with other lysosomal storage disorders to try and advocate for that. And We can do that on a national and international platform, and we're learning that. And I think there is a lot more strength in numbers to try and do these things. And so there's my son, and there's Everin, who's one of the other advocates who's written a children's book and done some other things about his experience with this. This guy is living with ASMD, has for 2 decades, and just graduated from university here, and he's going to teach special ed. And he's there with my son at one of the last conferences. So that's me putting in a shameless plug of my son and Everin, who's just one of the many outstanding advocates in this space. And so with that, I'm done. I hope people have questions. I really want to thank Mandy. I want to thank Deanne. I'm sorry about being a little late and getting on, but I appreciate you fitting me in. And hopefully I get to see you next year in person. Thanks.